Any slides, sir?
50. అనిపిస్తుందా?
Clear గా.
Okay. Diabetic dyslipidemia.
Hmm.
So this is the transport of the lipids. This picture is in the from the brown walls. So basically the main goal of the lipid transport system is to
సమరా అండ్ సాగర్ లో ఉన్నాడు.
ఏ వీడియోలు ఆపేయండి.
సరే సరే చెప్పు.
ఓకే,
మెయిన్ గోల్ ఆఫ్ లిపిడ్స్.
ఒక్క నిమిషం. సో so this is the basic essence of the lipid transport system. This picture is from the brown walls. So the two main goals of the transport system is to transport the lipids which are digested from the intestinal tract, that is intestinal pathway, and to make the lipids reach the places where they are needed. And the second pathway is the hepatic pathway, where in times of fasting, when there is no available food, the already existing reserves in the form of the lipids lipids will be converted to the energy. So that is by hepatic pathway. So an overview. So when we consume food, the lipids will be absorbed and chylomicrons will be formed, and the chylomicrons will be broken down by the lipoprotein lipase into the chylomicron remnant. In the process, free fatty acids will be released, and this will be circulating in the circulation, and it will reach the places like muscle, where it will be catabolized to meet the energy requirements. And the next thing is the hepatic pathway. In times of fasting, the energy should be the energy which is already stored should be converted into the lipids and released into the circulation. So liver forms both lipoprotein A as well as VLDL, and the VLDL by the same lipoprotein lipase will get broken into the IDL. In the process, it will release the free fatty acids. So the IDL has two fates. It will get converted into the LDL predominantly, and the LDL and the IDL can have the exchange of the triglycerides with the HDL. That HDL is mainly for the reverse cholesterol transport. So this is the basic overview. So going to diabetic dyslipidemia, the lipid profile in type 1 diabetics with a good glycemic control is identical to the general population. That is it is supernormal. In contrast, even with good glycemic control, type 2 diabetes patients have dyslipidemia. The poor glycemic control in diabetes type 1 and type 2, it decreases HDL-C and increases triglyceride levels. So these two are predominantly seen because of the poor glycemic control. And there can also be a surge in LDL-C with poor glycemic control, usually in the form of small dense LDL subfraction on account of rise in triglyceride levels. I will explain this. Collectively, these changes, that is decrease HDL, increase triglycerides, and increase small dense LDL, will cause accelerated atherosclerosis even before the diagnosis of diabetes. So epidemiology, as we know, type 2 diabetes is the most common type, consisting of 90% of diabetes population, and there is almost 85% prevalence of dyslipidemia in males, and 97%, almost reaching 100% in females. And in those dyslipidemia, hypercholesterolemia, that is increased LDL-C, non-HDL, is seen in 58%, whereas only isolated hypertriglyceridemia is seen in 36%. Whereas mixed, that is all the three components, increased triglycerides, high small dense LDL, and low HDL, they are seen in about 12% in males and 24% in females. And when going to the type 1 diabetes, there is a prevalence of 26%. That is about 1/4 of the population of type 1 diabetes will be having dyslipidemia. In that, the hypercholesterolemia is seen in 15% and hypertriglyceridemia is in 12%. So all patients with diabetes, if they are having dyslipidemia, everything cannot be attributed to the diabetes alone. The diabetic patients also can have primary dyslipidemias, that is familial hypercholesterolemias, which can be attributed to the single or multiple gene mutations. And we can see hypertriglyceridemia, that is, if it is more fasting serum triglycerides more than 150, but ideally the optimal level should be 100, but we take 150 as the cutoff. And there can be mixed dyslipidemia, that is increased LDL and triglycerides and reduced HDL. This is often encountered in diabetes as well as metabolic syndromes as well as in impaired glucose tolerance. So dysbeta lipoproteinemia, this is one disorder which looks similar to the diabetes dyslipidemia, but it is not so. This is predominantly because of apolipoprotein E and E2 homozygotes. So what happens in this dysbeta lipoproteinemia? The remnant lipoproteins are accumulated. So it will lead to a mixed dyslipidemia, which looks almost exact like diabetic dyslipidemia, but it can be differentiated by doing ApoB. This I will explain later. So what happens in we should suspect a dysbeta lipoproteinemia in a patient with diabetes when the patient has relatively low concentrations of ApoB compared to the total cholesterol concentration. If a patient comes with this increased LDL, increased triglycerides and decreased HDL, if simultaneously we perform the ApoB, if ApoB is low, then that is dysbeta lipoproteinemia. If ApoB is high, then it is mostly because of diabetic dyslipidemia. And also we should evaluate for secondary cause of lipid disorders, that is alcohol intake, hypothyroid, liver and renal disorders, obesity, aging, postprandial lipemia, metabolic syndrome, pregnancy, smoking, acute stress, and drugs like estrogen medications and HIV, and therapy like antipsychotic medications, steroids, and immunosuppressive agents. So what is the pathophysiology? So these three parameters, increased triglycerides, low HDL, and increased small LDL, can be detected years before the diagnosis of diabetes in insulin-resistant pre-diabetic individuals with normal glucose concentrations. Thus, we can derive from this that hyperglycemia alone cannot fully explain the lipid changes. So what is the culprit? The main culprit is the insulin resistance, not the hyperglycemia. So the elevated triglyceride levels, they are the result of, it can be either due to increased production or decreased clearance of triglyceride rich proteins in both fasting and non-fasting states. So if it consider increased production, so increased production in the form of increased VLDL from the liver. This is the main transporter of fasting triglycerides, because in fasting state, the liver will start producing VLDL to release the energy to the muscles. So this will be, the production of the VLDL is increased in diabetes.
Hello, sir. No, sir.
So this will be the predominant feature of the insulin resistance. And also postprandial hypertriglyceridemia is also another feature. In fasting stage, it is because of increased VLDL, whereas in postprandial, because of the increased absorption in the form of carbohydrates or lipids from the intestine, will also cause postprandial hypertriglyceridemia. So this is because of the intestine. So this is the first reason is increased production. The second reason is decreased clearance. So intestinal derived chylomicrons, they compete for the same clearance pathway as the hepatic derived VLDL. Thus, elevated intestinally absorbed chylomicrons can lead to the prolonged persistence of VLDL in plasma and vice versa. So both intestine derived chylomicrons and liver produced VLDL, both will be increased, and both the catabolism is decreased. So this will lead to increased triglycerides in the blood. So in the pathophysiology, there are various factors. Insulin is involved in all stages of VLDL production and secretion. In adipose tissue, what insulin does, we have to remember, is when if in a normal person, if a patient has adequate amount of insulin, we can take the example, if a patient is taking insulin, there will be a relatively higher chance of increasing weight. So this can be derived by this thing. In adipose tissue, insulin suppresses the lipolysis. So what it does is, it stores the energy. it makes the body store energy, not to release the energy. So in adipose tissue, insulin will suppress the lipolysis. How does it do is by it does it by inhibiting the activity of hormone sensitive lipase. So what does it do? Hormone sensitive lipase, it catabolizes the energy sources and release the free fatty acids into circulation. So what insulin does it? Insulin goes and inhibits the hormone sensitive lipase. So thus insulin regulates the amount of circulating free fatty acids, which acts as substrates and regulatory factors for VLDL assembly and secretion. And in liver, insulin also inhibits the transcription of microsomal triglyceride transfer protein, which mediates the transfer of triglycerides to the ApoB, which will both combine and form VLDL in the liver. So it will inhibit the transfer of the triglycerides. And also we can in type 1 diabetes, those who will be completely dependent on insulin, it will increase the activity of the lipoprotein lipase in skeletal muscle and the adipose tissue. It will catabolize the VLDL and reduces LDL and triglycerides. So that's why if a patient is having good glycemic control in type 1 diabetes who is completely insulin dependent, the lipid profile will be absolutely supernormal. So as I told, what does insulin do is insulin inhibits the hormone sensitive lipase. So this hormone sensitive lipase will 1 minute. This hormone sensitive lipase will be inhibited. So basically it will prevent the free fatty acids from coming into the circulation. And next going to ApoB. So whereas the VLDL free fatty acids are increased in circulation both because of increased production and decreased clearance. ApoB, the production of ApoB is relatively constant. It is not increased. But what happens in dyslipidemia, diabetic dyslipidemia, is the amount of ApoB released is determined by its rate of degradation rather than the rate of formation. So the increased hepatic availability of free acids, it leads to decreased degradation of ApoB. Thus, what it does is it combines with the available free fatty acids and it will become VLDL in insulin resistant state. So basically the production is not increased, but the catabolism is decreased. So ApoB analysis is recommended for risk assessment, particularly in people with high triglycerides, diabetes, obesity, and metabolic syndrome, or very low LDL-C. This I will explain later. It can also be used as an alternative to LDL-C, and also it can be used to differentiate the dys-beta lipoproteinemia from the diabetic dyslipidemia. So ApoB, basically ApoB combines with the free fat triglycerides in the liver and it forms VLDL. So ApoB, the rate of generation will be normal, but the catabolism will be decreased. Next, going to lipoprotein lipase. Lipoprotein lipase, as we know, it is a key enzyme in the VLDL, IDL to LDL delipidation cascade. So elevated free fatty acids will directly disrupt the activity of the lipoprotein lipase. So this is the lipoprotein lipase. So increased free fatty acids in the blood will inhibit the lipoprotein lipase. So what happens is the VLDL will increase, and also here the chylomicrons will increase in the body. This will lead to the increased triglyceride content in the blood. Next, going to the VLDL. So VLDL also, again, it can be divided into two types. One, type 1 and type 2. Type 1 is relatively triglyceride rich and type 2 is not. So basically in diabetic dyslipidemia, the type 1 increases. So it has high triglyceride content. The VLDL, there are two types. So the type 1, which is triglyceride rich, is increased in diabetic dyslipidemia compared to the type 2. So ApoC3, this is a bad apolipoprotein. So we don't want it in excess quantities. So what happens in diabetic dyslipidemia? It is a known inhibitor of lipoprotein lipase. So ApoC3, it hinders the hepatic uptake of triglyceride-rich lipoproteins by interfering with binding of ApoB lipoproteins to the hepatic ApoB or ApoE receptors. So whenever the triglyceride-rich proteins are in the circulation, it will be engulfed by the liver receptors. So ApoC3 will inhibit that. So the expression of the ApoC3 is induced by the glucose and inhibited by the insulin. So if a patient has hyperglycemia and relatively insulopenia, then the ApoC3 will increase. And also it will inhibit the uptake of the triglyceride-rich proteins, which will lead to increase in the free fatty acids. So decreased HDL. How the HDL will decrease? So diabetic patients have basically increased triglycerides in both fasting and non-fasting. This is all derived from all the previous explanation. So what this hypertriglyceridemia does is it will increase the enzymatic activity of CETP. What is the CETP? This enzyme will transfer the triglycerides from the HDL. From triglyceride-rich lipoproteins to the HDL and LDL in exchange for cholesterol esters. So what happens? This lead to increase in the triglyceride content in the HDL and LDL. So this triglyceride-enriched HDL particles are subjected to increased catabolism. Consequently, the plasma half-life of the HDL will decrease and they will get catabolized and excreted in the kidney, excreted via urine through the kidney. So this leads to the decrease in HDL. So this is the basic pathophysiology. So in the liver, the glucose free fatty acids will increase. So the ApoB production, the ApoB 48 from the intestine and the ApoB 100 from the liver. So basically the production rate will be constant, but the catabolism will get decreased. So basically the amount of the ApoBs in the blood will increase. And also the chylomicron absorption is increased and the VLDL production is increased. This is the liver hepatic pathway. This is the intestinal pathway. This will lead to increased triglyceride-rich lipoproteins. So then these lipoproteins, this is the CETP. So this what the CETP does is this will transfer the triglycerides from the triglyceride-rich lipoproteins to the HDL. So the triglycerides will get transferred from here to here, and the cholesterol esters will get transferred from here to here. So this HDL will become abundant with the triglycerides. So this will be catabolized early. This will lead to the decrease in HDL. In the same way, the triglycerides will get transferred to the LDL. This will form small, dense lipoproteins, which are very much atherogenic compared to the normal LDL. So this is the same pathophysiology explained, the liver hepatic pathway. So this will lead to increased VLDL and it will get transferred to the HDL, the triglycerides, and it will get catabolized. The same way, LDL and small, dense lipoproteins are formed. So the overall lipid abnormalities in type 2 diabetes are elevated VLDL, hypertriglyceridemia, low HDL, small dense LDL. But the total LDL cholesterol is usually not elevated. Only the small dense particles are elevated. So that's why measuring only LDL in diabetic patients cannot accurately quantify the ASCVD risk. So increased lipoprotein and glycosylated and oxidized LDL are also increased. So LDL-C is markedly increased only if a patient is having diabetes along with a nephrotic syndrome, but it is usually normal in diabetes patient without proteinuria. So contribution of different lipids in the pathogenesis. At present, LDL cholesterol remains a strong independent predictor of CVD in diabetic patients, even when the LDL is below the target, that is 130. The Strong Heart study observed a 12% increase in CVD in diabetic patients with every 10 mmHg increase in the LDL cholesterol. Although triglycerides are not directly involved in the development of atherosclerotic lesions, because free fatty acids released from the triglycerides act as either active energy source or stored energy reserve. However, the triglycerides are transported in ApoB containing lipoproteins, which may induce atherosclerosis similar to the LDL. So in that way, it can cause ASCVD. So that's why it is a secondary target. The most important anti-atherogenic of HDL is reverse cholesterol transport. Because the HDL is decreased, it cannot do. And the HDL also have other cardioprotective functions like antioxidative, inflammatory, and endothelium dependent vasodilatory effects. So what are the treatment targets? Although hyperglyceridemia is predominantly seen, it is not the primary target. So the ADA, ESC, and EASC recommends reducing LDL to less than 100 for diabetic patients without additional risk factors. Whereas high-risk patients, they advise less than 70. If this cannot be achieved, at least 30 to 40% is recommended by ADA, and more than 50% reduction in LDL from the baseline value is an alternative goal. So what are the secondary targets? Due to the predominance of small dense LDL, diabetic patients, they have increase in the LDL particles rather than the LDL concentration. So if we measure only the LDL concentration in the lipid profile, we are misleaded. So LDL concentration does not actually reflect the number of LDL particles, because the amount of cholesterol each particle carries varies. Since each LDL lipoprotein particle, as well as VLDL, IDL, and lipoprotein, these all lipoproteins have one ApoB. So measuring ApoB rather than LDL can be a surrogate marker of the total atherogenic lipoproteins. So ApoB can be used. So ApoB, and also one of the simplest way is measuring the non-HDL cholesterol. So that is also like a surrogate marker. So we can take the help of the non-HDL cholesterol as a secondary target. So the advantage of measuring non-HDL is it is cost effective, because we can simply derive the non-HDL cholesterol from the already existing lipid profile rather than measuring ApoB, which is a different blood test. So the secondary targets, both ApoB and non-HDL cholesterol, are currently regarded as secondary treatment targets due to the lack of evidence showing that decreasing the ApoB or non-HDL cholesterol is superior to targeting LDL, because there are no randomized control studies. It is considered a secondary target. And the ADA recommends the target is non-HDL less than 100 and less than 130 for patients with or without risk factors. And if ApoB is used, less than 80 and less than 90 for with or without risk factors. Similarly, triglycerides and HDL cholesterol are also the secondary targets. The triglycerides are less than 150 should be targeted, and HDL should be more than 40 in men and more than 50 in women. So the management. So obesity and insulin resistance are obviously closely related. So weight loss is an important treatment goal. At least 5% of the weight loss, that is moderate weight loss, is associated with improvements in insulin sensitivity, glycemic control, and lipid profile. And the carbohydrates should predominantly come from vegetables, fruits, whole grain, legumes, and dairy products, rather than that contain added fat, sugar, and sodium. So leaner protein sources and meat alternatives are preferred, and the dietary fat should be mainly mono and polyunsaturated, that is MUFAS and PUFAS, instead of saturated and trans fat. So those who consume alcohol, so moderate consumption, that is less than 1 drink per day for women and less than 2 drinks per day for men, is advised. And tree nuts, they are the very rich, they have very rich source of PUFAS, and they have shown to reduce cardiovascular events, particularly through reduction of ApoB and non-HDL cholesterol. So nuts belongs to a broad food category of seeds, which includes legumes, whole grains, cocoa products, and coffee. And dietary fiber consumption is encouraged. And there are many diets which have been tried, that is low carbohydrate diet, low glycemic index diet, Mediterranean diet, and high protein diet. They all improved the glycemic control compared to the respective control diets, with the largest effect observed in Mediterranean diet. Low carbohydrate and Mediterranean diets produce greater weight loss. So physical activity. Before prescribing a physical activity for a diabetic patients, we have to assess the risk, ASCVD risk of the patient. If needed, we can do a treadmill to rule out both silent IHD as well as to estimate the exercise tolerance. And after that, we can advise the physical activity, this thing. So if a patient is sedentary, and if a patient is exercising not regularly, and if a patient is regularly exercising, we can divide them into 3 categories. So we have to advise him to attain at least 40 to 60% of maximum heart rate. Here it is 50 to 65, and here it is maximum 85%. That is usually we do a treadmill for at least to achieve 85%. So this okay. Meeting will be ended in 10 minutes anta. Hello.
ఎన్ని స్లైడ్స్ ఉన్నాయి ఇంకా?
వై
చెప్తాను మరి ఫాస్ట్ గా ఎండ్ అయితే మళ్ళీ ఇంకోటి క్రియేట్ చేస్తాను.
చెప్పు ఫాస్ట్.
Okay. Drug therapy. So normalizing blood glucose levels is the top priority. and especially for normalizing, we have to use incretin-based therapy and glitazones. And the statin-based lipid-lowering therapy, it is shown to reduce the cardiovascular mortality and morbidity. So drug therapy, the CARDS, which was the first large primary prevention study to see the effect of statin without pre-existing CVD, the results showed that at least 10 mg of atorvastatin was associated with almost 37% reduction in the major ASCVD, and particularly even more higher chance of decreasing in the incidence of stroke. Many diabetic patients remain at the higher risk for cardiovascular events despite their low LDL goals. This residual risk is attributed to elevated triglycerides and low HDL. So the beneficial effects of the statin, they are still outweigh their potential diabetogenic effects. The CETP inhibitors, that is ezetimibe, in combination with simvastatin, was more effective in reducing the LDL and non-HDL and total cholesterol by HDL ratios when compared with doubling the dose of simvastatin. Niacin, the combination of niacin and statin has not been shown to provide additional cardiovascular benefit when compared with statin monotherapy in AIM-high and HPS Thrive. Fibrates, the fibrates can be used to treat isolated hypertriglyceridemia. The combination of statin should be considered on individual basis. The subjects at high risk with high triglyceride levels and low HDL levels may benefit from combination therapy. These have been studied in ACCORD. In ACCORD, it is actually a negative trial, but the post hoc analysis, both Field and ACCORD, they have done a post hoc analysis which has shown that fenofibrates have reduced events by 30% in those subset which has elevated triglycerides more than 200 and decreased HDLC. Both should be present. And in the ACCORD also, same thing was seen. Those patients who are having high triglycerides and low HDL are benefited along with the statin if they have these two fulfilling criteria. So bile acid sequestrants, the cholesterol, but the cholesterol lowering effects is usually accompanied by increase in the triglycerides. We should be aware of that. And diabetic patients may also benefit from the favorable effects on glucose homeostasis. It will decrease the HbA1c as well as the lipids. It is considered second line treatment to decrease the LDLs in a patient who are statin intolerant, not for triglycerides. It will increase the triglycerides, whereas it will decrease the LDL. So omega-3 fatty acids, there are 3 trials. The reduce it trial, it examined 2 grams BD of icosapentail ethyl. So in 8,000 patients who were already taking statin, so 25% reduction in the composite primary outcome was seen. And the strength trial is investigating the omega-3 fatty acids in addition to statin individuals with high triglycerides and low HDL who are at risk of CVD. The origin trial, who are at risk of cardiovascular events and had impaired fasting glucose, impaired glucose tolerance and diabetes, they are randomized to 1 gram supplementation. So in the follow-up, they have seen that the mortality benefit was not there. So basically, if a patient is having a isolated hypertriglyceridemia, we can use fibrates and plus or minus omega-3 fatty acids, but the role of statin is unclear. Whereas if the patient is having mixed dyslipidemia, that is especially elevated LDL cholesterol, we can start with statin and we can go with combination therapy on individual basis. So this combination, so if a patient is having isolated triglyceridemia that is more than 150, we have to start with the fibrate, start with fenofibrate. If it is still not controlled, add a fish oil or a niacin. If a patient is having mixed hypertriglyceridemia, and it can be divided into two, if a patient is having high risk or low risk, if a patient is having high risk, the target should be less than 70, low risk target should be less than 100. So both should be started on statin. If in spite of that the goal is not achieved, we have to add ezetimibe or fenofibrate. The same way we have to add ezetimibe or fenofibrate. So statins lower the triglycerides by 30%. HDL, it will increase the HDL by 5 to 10%, and it will reduce the LDL fluvastatin, pravastatin, and lovastatin by 20 to 40%. More potent statins which we use are atorvastatin, rosuvastatin by 30 to 60%. So statin therapy reduces the MACE by 23% per 1 millimole per liter reduction in LDL-C. And fibrates lower the triglycerides by 40 to 50% and raises the HDL by 10%. Niacin lowers the LDL by 5 to 15%, triglycerides by 20 to 50%, and it also lowers the lipoprotein A, and it also increases the HDL-C. This is the only drug which can increase the HDL-C by 15 to 30%, and it is predominantly used if a patient is having both hypertriglyceridemia and low HDL-C, not for decreasing the LDL. And ezetimibe is an add-on drug for a statin which reduces the LDL-C by 18% and lipoprotein A by 7%. So guidelines. So four or five slides on guidelines. So these are ESC 2019 guidelines. So it divides the normal individuals, those who are not having diabetes, into different risk categories. So this is basically a very high risk, and moderate risk. So very high risk, the patients will be having very high risk, especially in consideration of diabetes, the diabetes mellitus with target organ damage, or at least 3 major risk factors, or early onset of type 1 diabetes of longer duration, this more than 20 years, are very high risk. If a patient is more than 10 years, that is high risk. If a patient is having less than 10 years of diabetes, it is moderate risk. And the risk scoring, which is usually used, it should be used for patients who are not having diabetes, because if a patient has diabetes, he will already come under very high risk or moderate risk. And the treatment goals for the low risk, this is basically the score. These are all pooled cohort equations used to classify the risk. This is not used for diabetes patients. This diabetes patient, if it is young, diabetes less than 35 years or less than 50 years, and the duration is less than 10 years, he is coming under moderate. So the target will be 100. The high risk diabetes patients will be the targeted at 70, and the very high risk will be 55. So ESC, the non-HDL cholesterol is also recommended, class 1 recommendation, and ApoB analysis is also having class 1 recommendation. So diabetes, the side effects can be, it can have a minor but not clinically relevant elevation in HbA1c is also observed. The number needed to cause 1 case of diabetes has been estimated to be 255 patients over 4 years of statin treatment. The risk is higher if more potent statins are used, if a patient is elderly, and if a patient is already having insulin resistance or overweight. So, but in spite of all these things, the absolute reduction in the risk of CVD in high risk patients clearly outweighs the adverse effect of small increase in the incidence of diabetes. So type 1 diabetes, they are having high CVD risk, in particularly those patients who are having microalbuminuria and renal disease. The lipid profile is absolutely normal if they have good glycemic control. Because the patients will be using insulin, they have increased lipoprotein lipase activity, so which will decrease the VLDL particles. In spite of that, few patients will be eligible for statins. The statins yielded 9% reduction in the all-cause mortality. The use of statins will have similar benefits in diabetes type 1 and type 2. So the statins should be started regardless in a patient's if 40 to 75 years of age, regardless of the estimated 10-year ASCVD risk, that is the class 1. So the class 2 is even in a patient with diabetes with in age group of 40 to 75, this 40 and 75 are chosen because if a patient is less than 45 and more than 75, we have to individualize the